My name is Moira Sykstus, and I am the Director of Reimbursement and Clinical Services for Kent Imaging. Kathleen, Schaum, and I would like to welcome you to our chat about the Category 3 CPT codes for near-infrared spectroscopy and the rules and regulations and publications that have been put forth for 2022. And I do want to take a moment to thank Kathleen very much. She is a mentor and the guru of all things wound care reimbursement related and many other things. So I'll let her complete her introduction.
Moira, thank you very much for inviting me. I'm honored to be participating today. And I am the president of Kathleen Schaum and Associates in Lake Worth, Florida. And my contact information was on the slide.
Let's get the legal things out of the way, shall we? We want to make sure that everyone is aware that the information that Kathleen and I share with you today is as a courtesy. All information around payment and reimbursement must be cleared with the specific payers, and it very much depends on the individual circumstances of the listeners out there. So we encourage that you do that because nothing construes a guarantee of payment. And the last but not least of our legal disclaimers, CPT is a registered trademark of the AMA and owned by the AMA. So all things CPT belong to the AMA. And SnapshotNIR is a registered trademark of Kent Imaging. So let's get started. Kathleen, can you please explain the new CPT Category 3 codes that the AMA put into effect in 2021?
I would be very glad to. We're very fortunate because on July 1st, 2021, the AMA awarded Category 3 codes to this new technology. And the descriptor of the 3 codes is the same for the base of the code. And that descriptor is long, but it is very descriptive of what this technology does. And it's non-contact, near-infrared spectroscopy studies of a flapper wound. For example, the measurement of deoxyhemoglobin, oxyhemoglobin, and the ratio of tissue oxygenation. Now, then the 3 codes describe what portion of the study that you completed. So the first code, 0640T, is for the person who would do everything. They would acquire the image, they would interpret it, and they would write the report. And that code is for each flap or wound. Now, the second code is 0641T, and that is for the person or provider that did the image acquisition only. And again, it's per flap or wound. And the third code is 0642T, and that is if you only did the interpretation and the report. So you can see if you start from bottom up, if you only do the interpretation and report, 0642T. If you only do the image, 0641T. But if you do everything, then it's 0640T.
So why are the new codes, the CPT Category 3, why are they called Category 3 codes or T codes?
Actually, that's the Category 3 is the name of the code, but T code is kind of the way kind of a nickname for those codes. So let's talk about how the AMA awards Category 3 codes. Actually, Category 3 codes are a relatively new phenomena with the AMA, and we're very thankful for that opportunity because in the past, we had to wait for the long process to be awarded a Category 1 code. And new technology would come to the market, and we would not be able to get it used fast enough because we were waiting for this several-year process to get a Category 1 code. So AMA came up with this Category 3 codes that allows emerging technologies and services and procedures to have a code that are not yet ready to have their Category 1 code awarded by the AMA. So that's what category 3 means. It means it is a code for emerging technology. Now, then where does it get the nickname T? Well, all CPT codes have 5 digits. And this code really has 5 also, except the format is there's 4 numbers and it's followed by the letter T. So that's how they get called a T code. Now, why are these codes so very important? Besides giving us the opportunity to utilize the technology early after its development, the codes allow us to help the AMA and the payers to collect data. So while we're using the technology, now there's codes to collect the data so that they can determine the clinical efficacy and how widespread is its usage and what are the outcomes of using the technology. Now, these codes are temporary. We only get them for 5 years. So we want to be sure at the end of the 5 years that we will be able to convert to a category 1 code, but it's not a guarantee. And it really depends on the data that's collected and the usage of the technology. So my friends, category 3 codes for this technology are great news for the wound and ulcer management industry. It provides you quicker patient access to the emerging technology, and it actually allows you to establish the utilization and to build support for advancing the technology to a CPT category 1 status.
So, Kathleen, who can build these codes? Can physicians and qualified health professionals build them? Can hospital, outpatient departments, HOPDs build them? Talk to me about that.
Yes, Moira, they can report the base code, but they're each going to use one of the 3 codes at the appropriate time. So let's first talk about how physicians and QHPs would use the codes. And reminding you that QHP is an acronym for Qualified Healthcare Professional, and those are other professionals who can write orders and people like nurse practitioners, physician assistants. So for the code 0640T, remember I said that is for the person who does the entire process. They acquire the image, they do the interpretation, and they write the report. So in a physician's office, if they have done all of that, they own the equipment and they have done that, and they billed under their same tax ID number, then indeed they can use 0640T. So pretty much that's the code for the physician office. Now, if that same physician or QHP goes out of their office and goes to a hospital outpatient provider-based department, which you might call a wound care center or a wound care department, but the official name is PBD. If they go over to the PBD, now the PBD typically owns the equipment. And so they would be acquiring the image upon the order of the physician, but then the physician would do the interpretation and write the report. So in that case, the physician or QHP would only use the code 0642T because they did the interpretation and the report only. Now, I really want to bring to your attention, and we will say this several times, I'm sure, but these codes are meant to report the number of units that you did based on the number of flaps or wounds imaged. So we will go over that, I am sure, multiple times because this is an important point. Let's talk about how the PBD or provider-based department would use these codes. Keep in mind, most of the time the PBD would own the device. And therefore, they own the device, and upon the direction and an order of a supervision of a physician, they would acquire the image. So in that case, they would use the code 0641T because they own the equipment They acquired the image. And I'm bringing this to your attention that it is required that this be done under direct physician supervision. Now, there may be a few instances where the physician or QHP actually owns the equipment. The provider-based department doesn't own it, and the physician or QHP may make a contract with a provider-based department to come in and to provide the NIR study. If they do that, then the physician is going to bill for everything, because the provider-based department really is not participating in that, because it's not their equipment. The physician took the image, the physician did the interpretation and the report. And again, we're reminding you that to report the number of units based on the number of flaps or wounds imaged.
So can more than one unit be billed on the same date of service by any of the qualified health practitioners or by a hospital outpatient department?
The answer is actually in the code description. All right. And the code description clearly says each flap or wound. So if indeed we did an image of a wound on the left leg and we did another image of a wound on the right leg, then indeed we would be able to report 2 units, because it was 2 different wounds or 2 different flaps. But there are sometimes a physician might want to take multiple images throughout a procedure, maybe before and then after a procedure. If the physician ordered that, you would not get to bill for each image of the same wound. You would only get to bill that imaging one time. So that's the difference. So you get to bill for 2 units if you did 2 different wounds. But if you did 2 images of the same wound, you only get to bill for 1 unit.
So Kathleen, can you tell me, before we got the Category 3 codes assigned to us last year, the physicians and QHPs and hospital outpatient departments were using some unlisted codes. Can they still use those codes?
Let's remember the one basic coding rule. Once a code exists, it must be reported. And the physicians and QHPs and PBDs who perform the NIRS studies after July 1st must report the correct 0640T, 0641T, and 0642T code. Whichever one of those codes aligns with the work they perform, they must use those. They cannot gravitate back to using unlisted codes, because quite frankly, that would be a false claim. So the Category 3 codes are a gift to us, and we definitely should be using them. So then, Moira, do the commercial and private payers recognize the CPT Category 3 codes?
Thank you so much for that question. I get it quite often. So there's a couple of different things we want to look at. First of all, recognize is sort of an interesting term. When the AMA issues a CPT code, it is what it is. People have to recognize it. Now, payment is a whole different story. Medicare may say that a code is payable and assign it a HCPCS code that's payable, but commercial insurances, especially with T codes, decide what they choose to reimburse and what they choose not to reimburse. Many of those decisions are based not even specifically about the payor, like United or Aetna or Cigna, but based upon the individual coverages that one patient may have. So one United policy might not cover a Category 3 CPT code or HCPCS code, where another United policy may pay very well for that very same code. So many of these things have to be investigated by policy and even to the level of patient benefit. So, Kathleen, for 2022, did Medicare or CMS publish any rates for payables for Category 3 CPT codes, especially those that we're discussing today, the 0640T through 0642T code?
So we have to think about the 2022 Medicare allowable rates separately for the physicians and QHPs and the provider-based departments. Medicare publishes the allowable rates every year in the Medicare physician fee schedule. And when you look in the Medicare physician fee schedule for 2022, for the codes that belong to the physician and the QHP, those codes 0640T and 0642T say contractor priced by them. And that is not unique for the NIR technology. All products that have a Category 3 code, Medicare writes contractor priced in the physician fee schedule. And then they turf over the decision about the relative value units and the payment rate to each Medicare administrative contractor, or better known as the MAC. Now, at first, the MACs determine that on a case-by-case basis. They'll very often ask the physician who did the procedure to please provide the documentation so that they can better understand what was done. And they may even ask for, what should be the allowable rate, what in the physician's opinion should be the rate. MACs also might set a utilization guideline. Now, what's really interesting is that if indeed a physician is proactive and is going to use this technology, it's great if they would contact their medical director, introduce them to the technology, and really have the opportunity to show them what the advantages are to the patient, to the payer, and of course then to the provider. And then they may be able to get a special rate just assigned to them for a while. And then after they do the procedure for a while, that rate might, and other physicians in that particular state do the procedure or the study, then indeed we might see the MAC publish a rate on their fee schedule. So a lot has to do here with how well our physicians and QHPs educate the MAC medical directors. And also now for the PBDs, the Category 3 codes get assigned a rate on the outpatient prospective payment system fee schedule. And so keeping in mind, the provider-based department only uses the code 0641T. So that one code then has been assigned to an ambulatory payment classification group, and that's 5732. Now, the code also has a status indicator of T. And T means if you do more than one procedure that has a T status indicator, the first one would get paid at 100%, and the second one would get paid at 50%. And the national average outpatient prospective payment system rate for 0641T for this year is $34.57. And remember what I said, national average, because depending on your wage index in your particular facility. For example, you might be in California and this rate might be higher than it might be in Mississippi. So this is a national average rate, and also remember it's a rate for each flap or each wound that is imaged during the encounter. So Moira, now that I've told you about the payment rates, can you share with us, has Medicare published any payment frequency guidelines?
So here's the good news and the bad news about Category 3 codes. Category 3 codes, or T codes, are new codes. So because we're new, we don't have any LCDs that are applicable to us or NCDs that are applicable to us. That's local coverage determinations or national coverage determinations. So there aren't any guidelines that are published. There is a 0-day global, which means that there aren't any necessarily frequency guidelines that are prohibited. In other words, you can image the next day or the day after you do your first sets of imaging. But really, what I'd like to say is documentation, as always, is the key. While we're in this phase of the temporary code, everyone's going to be looking, as far as the payers, all the payers are going to be looking to see how is the device being used, what are they using it for, what value is it bringing, and the only way we can truly show them that is how it's documented. So really, if we can document medical necessity and we can show the value of the results of the NIR snapshot images, then we should do that. And because we are at this point teaching the payers how to treat us. So, Kathleen, can we take a moment and talk about coverage and payment? What do you think the physicians, qualified health professionals, and even the hospitals can do to help promote good decisions and good payment from the payers? Are there any specific actions that they can take that might help to push that forward or get them better reimbursement?
As you just mentioned, documentation is the foundation for obtaining payer coverage. And this is not just for the NIR imaging, it is for everything that we do in wound and ulcer management. And we sometimes fail to paint the picture for the payer. And remember, if we are purchasing something, we do our due diligence and we find out if it's worth it to purchase it. We look at the details about it, etc. And so when the payer is we're asking them to pay for something, basically we're asking them to buy what we are selling them. They really need to be seeing those same details. And documentation is so important. We just can't document, oh, we did a NIR image, because that will never ever fly with a payer. I mean, it doesn't even fly when we say we debrided a wound. So we have to say who performed the image. And remember how important that is, because there's different codes for the QHPs and physicians than there are for the provider-based departments. So it's very important to say who performed the imaging. And then what was the anatomic location of the wound or flap? Because remember, if you did two different anatomic locations, then you would get to bill 2 units. We also have to say, why was the imaging medically necessary? What is its role in us developing our plan of care or determining what procedure we are going to do for the patient? And then, of course, after we do the image, what were the results? And then how are these results of this study going to impact our medical decision making and our plan of care? So it's a very methodical painting of the picture, the who, where, why, what, and how of what we did. And I have to tell you, I visited the cantimaging.com website, and it's cantimaging.com/reimbursement. And I saw some very good detailed documentation guidance on your website. So for the listeners, I encourage you to go to that website and you'll get some very good tips for how to paint this picture for your documentation of the NIR studies. Now, Moira, we know that the emerging technologies with the Category 3 codes may or may not be covered by Medicare, the commercial, and the private payers. Can you tell us, as of today, what has been Kent's experience with coverage?
So, Kathleen, I can tell you what our experience has been with reimbursement thus far. I'd like to say thank you to all of those physicians and QHPs and hospitals out there that have been so wonderful to share data with us so I can actually have these conversations. We have seen some terrific response from some of our Medicare carriers. Noridian hasn't made a final decision yet, but we have received payment and pretty good payment from WPS, from First Post, Novitas, and we can add CGS to that as well. So, and as far as commercial payers go, we've seen really good payments from Humana, from Blue Cross, from United, from Optum, from Kaiser, Mutual of Omaha, HMO of Louisiana, Ambetter, MedPay Health, and several others. United has been interesting. You know, they're terrific in some parts of the country, and they're not so great in others. But all in all, I believe that we are seeing that the commercial and private payers have embraced the technology and see the value. I can't emphasize enough how important it is to verify coverage and call in and check. Talk to the payers, find out whether or not it's something that requires a pre-authorization or if the benefits even cover category 3 codes or this specific category 3 code. Each individual patient's plan may be different, so we can't make any assumptions. We've gotten payment from United, but that doesn't mean every United plan covers this particular service. So I encourage people to call anyone and everyone that the QHPs have decided, even in the hospitals or in the physician offices, if they've decided that they want to use the snapshot on a patient, then those patients need to have their benefits verified, and we need to verify whether or not a pre-authorization is needed. And keep in mind, even if a pre-auth is not needed, that doesn't guarantee payment. So we have to make sure that, again, our documentation is wonderful, because the way that we help the payers to understand the value of what we're doing is that we educate them. How we educate them is to appeal denials and share the information with them from our medical records and from articles. You know, there's a lot of different ways to educate a payer, and it doesn't necessarily always have to go from medical director to medical director or from provider to medical director. If we are sending in information with denials, then that helps too.
Moira, I think that that's a really good example of since there are 7 MACs, and you mentioned that 4 are covering, 1 is making decision, that makes 5. That means there's 2 left. All right. And I would highly encourage the physicians and the QHPs in those particular jurisdictions to reach out and educate those MAC medical directors about the advantages of using and paying for the NIR technology. And then we also know that it's important to always verify if the patient even has insurance to cover this. And we can do that for Medicare. But for Medicare is not going to always tell us every condition that they are going to pay for it for. However, we can get that information very often from the commercial payers. Can you tell us how important that is and exactly what we should do about that with the private payers?
I can't emphasize enough how important it is to verify coverage and call in and check. Talk to the payers, find out whether or not it's something that requires a pre-authorization or if the benefits even cover category 3 codes or this specific category 3 code. Each individual patient's plan may be different, so we can't make any assumptions. We've gotten payment from United, but that doesn't mean every United plan covers this particular service. So I encourage people to call anyone and everyone that the QHPs have decided, even in the hospitals or in the physician offices, if they've decided that they want to use the snapshot on a patient, then those patients need to have their benefits verified, and we need to verify whether or not a pre-authorization is needed. And keep in mind, even if a pre-auth is not needed, that doesn't guarantee payment. So we have to make sure that, again, our documentation is wonderful, because the way that we help the payers to understand the value of what we're doing is that we educate them. How we educate them is to appeal denials and share the information with them from our medical records and from articles. There's a lot of different ways to educate a payer, and it doesn't necessarily always have to go from medical director to medical director or from provider to medical director. If we are sending in information with denials, then that helps too.
Mara, I'd like to add something to that. In my consulting work, one of the mistakes that I see the wound care professionals and the provider-based departments make is when they're in this, what we call insurance benefit verification. Sometimes the very first question out of their mouth when they're talking to the payer is, would like to use this technology. Is prior authorization required? That should not be the first question, because they really should ask, is this covered on this patient's plan? We're checking the benefits for this patient. Is it covered on their plan? Then if the answer is yes, say, then is prior authorization required? If the answer is no, you want to say, well, is there a method we could use to try to get an exception for this patient because it really is important, and then find that out. Now, why did I make a big deal about this? Because if the first thing you ask them is prior authorization required, they may say, no, it's not required. And so you might assume, well, then it's covered on their plan. And then you go forward and you do the process and do the imaging. And then you find out that, well, it wasn't on their plan and the claim got denied. So you can't ask the prior authorization question first. You have to ask the insurance benefit verification. Is it covered on the patient's plan? And if yes, what about prior authorization? If no, can we get a prior authorization exception? I have one last question for you, Moira. What is the reimbursement assistance that the providers can expect to get from Kent in regards to reimbursement?
Thank you, Kathleen, for asking that. One of the things I love about Kent is that they have dedicated a lot of resources to making sure that all of our customers and providers have all the information that they need. So, the first place I always tell people to go to is the website. So thank you for bringing that up. The website has a bunch of different tools on it, and you can get there at www.kentimaging.com/reimbursement, or you can actually just hit solutions, the solutions tab, and scroll down to reimbursement on the Kent Imaging website. We also have a reimbursement hotline listed on there. So you can call anytime, and one of our team will answer the call. And if they can't answer the question, they'll make sure to find someone who can. There's also an email address, reimbursement@kentimaging.com. And either myself or one of my team will make sure that we answer that as quickly as possible. Our goal always is within 24 hours. Occasionally things get in the way of that, but we very routinely get there. And then, once you hit that reimbursement hotline, almost always during normal business hours, and that is about 16 hours a day, someone live will answer that call. So I want to thank everyone for coming and sharing this time with us to learn about the 2022 coding for the near-infrared spectroscopy. And Kathleen, thank you so much for taking the time to be with us. It's always such a joy, and I'm grateful. I hope everyone has a wonderful day.
Thank you for inviting me, and I hope this has been helpful to all the listeners.